Welcome to another episode of the Movement Revisionist Podcast, where I help you redefine human movement one episode at a time. And I have a very special guest for this episode. Actually, we just became best friends a week ago. But I'm here with Osama. We have a hot topic to talk about, especially when it comes to muscle and joint care, especially the more modern treatments that might go into that. But let's just start with who the heck are you and what are you about, man?
So my name is Osama Imam. I'm a physical therapist. Went to school at Wayne State University in Detroit. After graduating, I did a fellowship in orthopedics. At the time, it was based out of South Carolina, and it was a distance-based fellowship. So it was a lot of traveling for about 18 months as I obtained my fellowship. I also received a diploma in osteopractic, which is a subspecialty in orthopedics. And then after graduating, I decided to start a private practice. So now have a private pay physical therapy practice in Bloomfield Hills, and I teach dry needling for the American Academy of Manipulative Therapy.
That was a resume right there. Heck yeah. Well, I find it fascinating because you're an osteopractic physical therapist. So you know adjustments, not just spinal, but manipulative therapy, which is cool seeing the other side of things because like when people find out or I tell them I'm a sports chiropractor, they just think I adjust people all day. So I tell them, think of me as a physical therapist that does adjustments. You are literally the opposite side of that coin. You are the physical therapist that does adjustments as a physical therapist.
So part of my fellowship and getting the diploma in osteopractic, there was it's a big focus in manual therapy. So while we get trained in diagnosis and treatment of neuromusculoskeletal conditions, a big part of that is dry needling and spinal and extremity manipulation. Mm-hmm. So I do adjustments or high velocity, low amplitude thrust manipulation for cervical spine, which we were basically taught in physical therapy school that was not safe or that not really in our scope, I guess, at the time.
Yeah.
And we learned how to do adjustments for the thoracic spine, the lumbar spine, but we also do it for extremities as well. So we do combine a lot of treatment techniques from physical therapy, but also taking the best available literature from some chiropractic techniques and even from some acupuncture techniques as well. That being said, we don't do actual chiropractic methods. However, if there is literature that shows that a manipulation works well for headaches, we don't disregard that just because it was done by a chiropractor.
Right.
And there's plenty of manipulation studies that are done by physical therapists. A lot of our fellowship is actually doing the research ourselves. So part of my fellowship was doing research on tension type headaches, mm-hmm. and it was comparing traditional physical therapy, so a lot of exercises, joint mobilization, some soft tissue techniques, and TENS, so electrical stimulation.
Yep.
And we compared that to spinal manipulation, dry needling, and then the same exercises. So both groups got the same exercises, but then different modalities on top of that. And that was research done entirely by physical therapists doing spinal manipulation. So we take the best available literature and we perform a lot of the research as well. Regardless of what the profession is, if they do a technique and that is within our scope of practice, then we can still utilize that to get the best possible outcomes for our patients.
Heck yeah. Evidence-based care.
Exactly.
Literally, that's how you do evidence-based care right there. Yeah, so I find it fascinating. Well, we talked about it. We're going to dive into the topic of dry needling just because people are starting to hear about it more and more, especially on the patient side. Sometimes they're actually seeking it now. Most of them have heard of acupuncture, but we're going to dive into the difference of the different types of dry needling, which talking to you, I didn't know there were so many different ones, but maybe what people should look for, what's the difference with acupuncture. So let me just ask you, what the heck is dry needling?
So dry needling is the use of a monofilament needle. Essentially, it is a needle without any medication on it. That's why it's called a dry needle. And we are inserting these needles into specific structures in the body in order to induce a natural healing response.
Yes. Inflammation, but inflammation's good.
Yes. We're reintroducing inflammation in a controlled manner in order for the body to heal itself.
Yeah, so I'm excited to nerd out on this. We've already nerded out since we met each other last week. But like when I was going through chiropractic school, I did 100 hours of acupuncture. I did 50 hours of trigger point dry needling. Um, what is the dry needling technique that you're trained in and actually you train others in?
So we do some trigger point dry needling, but there's essentially dry needling or acupuncture is really an umbrella term. So acupuncture just means to puncture the skin with a needle. That is not the same thing as traditional Chinese medicine. So what I do has no relationship to traditional Chinese medicine. I am not trying to move energy or qi across meridians or anything like that. What I'm trying to do is induce a physiologic response by the body. So we do some trigger point dry needling in that we are trying to find trigger points in muscles and muscle belly in order to deactivate them. However, that is, if someone only does trigger point dry needling, they're really missing the boat. There's a lot more that we can use the needles for. The needle itself is just the tool. So
Right.
we're able to treat nerves, we're able to treat joints, tendons, ligaments, joint capsules, scars. A very, very underrated treatment is dry needling for painful or numb scars. So again, the needle itself is just the tool, but
Right.
we are not limited to only treating muscle. And if we only do trigger point dry needling, then we really are only limiting ourselves to treating the muscle.
Yeah, it's almost like me as a chiropractor. If I only adjust patients, I can get outcomes, but it's only one tool, right?
Exactly.
So when dry needling is, there's different kind of subsets within it, and you just need to know when that dry needling tool is applicable for that specific person, right?
Exactly. And even with the tool itself, with the needle, we are able to manipulate that needle in a few different ways. So you'll hear of most people that learn, especially trigger point dry needling, they'll do a technique called pistoning, just like a car piston. So they'll go back and forth into the same muscle fiber to get a twitch response. And their entire goal with trigger point dry needling is to get that twitch response, where the muscle will have a little bit of an activation,
Yep.
and then you can get that muscle fiber to calm down.
Which was when I took it 2018. That was like, hey, you knew you were successful if you got that twitch response, which we've talked before, but what's some of the research when it comes to that?
So the twitch response is it's nice to see if you're treating a muscle. It's cool to know that you're doing something. You know, if you see a twitch, you know you're actually doing something within that muscle belly. However, in the short term, there's a poor correlation with pain and outcomes if there is a successful twitch response. And then in the long term, there are no studies comparing a twitch response to a successful outcome. There's also multiple studies that show that there can be a huge amount of vasodilation or an increase in blood flow in the absence of a twitch response. So even if we don't get that twitch, there's still going to be a small microtrauma that we are causing, and we are reintroducing an inflammatory cycle and promoting more blood flow to the area. But with that being said, if we are only looking for the twitch response, then there's a lot of structures that we're not going to be able to target. And along with that, the twitch response is actually shown to cause, not the twitch response, but the pistoning technique where you go back and forth into a muscle fiber.
Yeah,
it's
where
actually shown to cause too much damage. So we are creating a little bit too much inflammation, and it's shown that after 3 days, there is axon regeneration. But axons only regenerate if they are damaged.
Right.
So doing that pistoning technique and going back and forth into the muscle fiber to get that twitch is just a little bit too much damage, and we want to have a controlled amount of damage for our patient.
Yeah, it's more on the aggressive side.
Exactly.
Yep.
And the first time that I ever got dry needled, I think I was in my first year of physical therapy school, and I had heard some things about it, and my clinical instructor did dry needling. So, I had some pain in my upper traps, but, I was a student, so I was sitting and studying all day.
Oh, I remember.
Exactly. So he did dry needling for my upper traps, and it was incredibly uncomfortable. I had the needles in for less than 60 seconds. It was kind of in and out. And he took the needles. I said, "Okay, you're all done." And I got up, and I felt sore as hell, and I stayed sore for probably something like 5 or 6 days. And then afterward, the pain came right back. So then I thought to myself, why would I ever put a patient through that? And looking back at it now, I now realize that he was just doing pistoning in my trap.
Yeah, it was just poor technique and probably not the tool you needed for which what you had going on at that time, right?
Exactly, and no fault of his. It's just the way that he was trained, and the way that a lot of people are trained in dry needling is to only look for that twitch response or to only do pistoning. They never leave the needles in situ. They don't really know how to manipulate the needle in any other way. They don't do any fanning or coning. They don't wind the needle.
Yep.
And these are all specific techniques that when we utilize them, we can have way better outcomes for our patient. We only will make them sore for maybe one day. They'll be a little bit sore the next day, but if they're sore for 2 or more days, we did too much.
Yeah.
That's exactly what I experienced the first time that I got needled.
Oh yeah. It's just like, well, especially coming back to like manipulations. Sometimes, like especially if someone hasn't been adjusted in a little bit or they've never been adjusted, I always like to tee them up where it's like, hey, you're feeling good now, you're moving instantly better, which means we got the desired outcome, but just know this hasn't happened before or hasn't happened in a little bit. So you could have a little bit of soreness the next day or even a couple days, like you just kind of worked out that area. That's a normal response. So if they get that for a longer period of time, it's either too much force or it wasn't the right tool for them at that very moment. Sounds like it's the same thing, just different modality, right?
Exactly, and just like how you explain it to your patient that way, I do the same thing. I want to make sure that they know what to expect, because otherwise they might think that we hurt them. If they're really sore, sometimes the first time that you're introducing them to a new treatment, I'll explain it to patients that it's the same way as cooking. If you're making a meal and you have a recipe and you add something new to that recipe, you might make it way better, but you also might have made the meal way worse.
Right.
So we have to make sure that we know what we're doing for our patient. If we add or remove something, that might get the right dose or that right recipe for that patient.
Yes.
So if they get if they get very sore, and they expect that they're going to have some soreness, but they know that it lasted a little bit too long, well, I already preface that, and I let them know that if you're sore for this long, then it's a little bit too much. Compared to if they don't get sore at all, we probably did too little.
Right,
you have to increase it. You
got to find that sweet spot. That's
Exactly.
where I like to tell my patients, short-term discomfort, hopefully not worsening symptoms, but short-term discomfort for those longer-term results. And if we can keep pushing to your threshold, not going over it, but pushing through it, we can just speed up the recovery time so much. So, and another thing to tee up is like when telling someone, hey, you might be a little bit sore afterwards, just asking them, hey, have you ever gotten a massage before? Sometimes that day of or that day after, man, you feel like you're bruised a little bit. That's a normal response when we're, moving areas or tissues that haven't moved regularly. So just teeing them up for success, because with clinical experience, we can kind of guide them based on our patterns before.
What we've seen with other patients.
So you try to, if you're anything like me, you're like, I'm not expecting this, but just so you know, there's like a 5% chance this might be the response, so just trying to tee them up with as much information as possible.
Also, a lot of the times patients will describe that their pain has changed in quality. So instead of it being like a dull, achy, or sharp pain, they'll say that the pain has changed into more of a soreness type of a pain.
Yep.
And then typically it'll also decrease in intensity. So
Yep.
it'll go from like, maybe a 6 out of 10 dull pain to maybe a 3 out of 10 soreness type of a pain. So both the quality has changed and the quantity of their symptoms.
Heck yeah. Yeah, I love it. I see we could riff on anything. So that's where we're trying to stay contained into, just dry needling today, but we can go into so many different topics.
Yeah.
Probably not the last time we're going to do one of these.
I hope
just
not.
so you know. But let's get back more into dry needling. So what is the specific qualifications you have and what you teach? I know you riffed your resume at the beginning, but let's go deeper into like your trainings and where you find those applicable when it comes to treating an area, say like, cervical genic headaches.
So for majority of things in the body, I would say that I could treat them without needles. But that being said, I would get better outcomes for that patient if I were able to introduce them to needling. There's plenty of people who don't want it done, and that's completely okay.
Yeah, you don't force
Exactly.
force
Yeah.
treatments.
No one really loves needles, but for those that have a true needle phobia, like we're not going to mess with needles.
Yes.
So there's other treatments that we can do, whether that be other manual therapies or exercise, or maybe it's lifestyle modifications. There's going to be some other way that we can treat that patient. However, if they are open to trying dry needling, and oftentimes people are finding me through Google, because there's a study that I just read just last week that said that there's an increased number of patients that are Googling dry needling. So patients are really seeking this treatment out.
Oh, yeah.
And it's up to us to be well trained in dry needling and making sure that we're getting them the best outcomes. Because again, if we do something that maybe made them a little bit too sore, or we we can't really worsen their symptoms, but let's say they didn't get any results, or we made them too sore as the result,
Yeah.
they're not going to want this treatment done again. So then we're doing that patient a disservice.
Oh, yeah.
So with that being said, I don't dry needle everybody, but for those that can benefit from it, I love to introduce them to it. So common ones are like for patellofemoral pain. There are studies that have shown that those that have failed traditional physical therapy were able to successfully get treatment if they were needled in, I believe it was their ipsilateral glute medius and their contralateral QL. There have been studies that have shown that you need to do manual treatments in order to have a successful outcome with TMJ dysfunction. One of the main reasons for that is we can't get to the lateral pterygoid intraorally. It's been shown in a cadaver study you can only get to the lateral pterygoid by the tip of your middle finger, and you have to kind of work your way around the medial pterygoid. So essentially, we're just sticking a finger in a patient's mouth.
And no one likes the medial pterygoid.
Yeah, it's
That'll bring a tear to your eye.
Not a comfortable technique. Also a little bit awkward. So with the needle, we can actually get to that lateral pterygoid and get way better outcomes that way. As for your question on cervicogenic headaches, with cervicogenic headaches, typically we're going to, we got to treat the neck. It's a cervical spine problem. So we can maybe do some soft tissue work, we can mobilize, we can manipulate the joint. But if we're also able to needle at the segments in their cervical spine where they're dysfunctional, or maybe we even follow their headache pattern, because typically they'll describe like that ram's horn distribution wrapping around their head, sometimes even into their eye. Well, we can needle them in the back of the head. We can even needle them around their eye. Like there's muscles in the face that we're able to target. But bringing it all the way back to only doing pistoning and looking for that twitch response, well, you're not going to get any twitches if you're needling in the head. There's no muscle up here in the head. There's an aponeurosis, but there's no muscle.
Right.
So
So then what do you do?
Exactly. So there's still ways that we can treat these areas with needles, even if we're not targeting muscle. That being said, in the head, we can treat the greater and the lesser occipital nerves. With cervicogenic headaches, there's some involvement from the trigeminal nerve, but we can needle right next to the trigeminal nerve. So we're essentially we're flirting with these nerves. We're getting really, really close to them in order to promote more blood flow and signal for the body's natural healing response in that area.
Yeah, I like to think of dry needling, even if you're doing just the muscles or following the nerve or whatever tissue you're going into, you're just kind of trying to reset that area back to, well, homeostasis is a common term, but getting it to calm back down.
And then from there, when we start applying our exercise, we can have a lot more bang for our buck. We essentially get this window of opportunity. So a common thing is like in the lumbar spine. Let's say somebody has some multifidi atrophy, which we know can happen in those that have an acute onset of low back pain. Within it's like 48 to 72 hours, they have some multifidi atrophy and fatty infiltrate. Well, we can needle down to the multifidi muscle, which is underneath 5 layers of muscle. So I can't get to it with my hands. We can affect it essentially through 3 means. That is through exercise, through spinal manipulation, and through dry needling. So if I can needle down to that muscle and then use electrical stimulation and get a low-grade muscle contraction at the multifidi, then we can do low load, but we can start to load them afterwards. So we start getting them moving a bit more afterward, and that way, again, we have this window of opportunity where they will have less symptoms and essentially have more benefit from that exercise that we are applying to our patient.
Yeah. Oh, I love this. Now I'm just curious. Well, I'm sure if someone like Google dry needling and that's how they found you, you're trying to implement that treatment as soon as possible, right?
Well, yeah, part of evidence-based practice is, clinical experience and
Yep.
patient expectations along with research.
Yes.
So it doesn't matter what the research says. If a patient doesn't want it, it'll never make them better.
Yeah.
So we don't do it. But if they come in and they're like, hey, this is something that, I think can really help me, then likely we can implement it. But we'll also have a conversation as to why, because and I've had patients come in asking for cupping, and cupping makes no sense for what they have
What they
going
have,
on.
yes,
Yeah.
yes.
So sometimes it's part of educating the patient as to what they need, and sometimes you have to give the patient a little bit of what they want, so you can give them what they need.
Oh yeah, absolutely. Well, I'm just curious. I mean, those you're probably already teed up that, hey, for sure, dry needling is going to be implemented in their care plan at some point. Might not be right away, and you might have to set those expectations depending on what's going on. But let's say it's someone who doesn't even know your dry needling that's coming in. When do you find that it's that time to turn it on? Do you go more kind of conservative manual therapy techniques first, and then if you don't see the outcomes, then you're like, time to whip out the big gun? Obviously research based,
Yeah.
but yeah.
So it'll be largely based off of, one, what we find during the evaluation. I typically don't needle day one. Day one is a lot more testing, giving them a little bit of the tool so they can be in the driver's seat and get their symptoms under control. But it also takes a little bit of time, so I don't want to really use our evaluation time to needle that patient. I might talk to them a little bit about it, and then we can, if they're interested, we can maybe do it the following treatment.
Yep.
But typically it's done earlier on in the treatment, so we can get their symptoms under control, and then I'll wean them off of needles and get them moving a bit more, because really that's what we need is more movement.
Yes, it's going to be more treatment clinician heavy on purpose. But well, we've already talked. I know how you practice is very similar to me, where it's like, hey, I might have to do some of the heavy lifting at first, but you don't want that clinician dependency. So like that's where you're dangling the carrot to where we need you moving more.
Exactly.
And giving those specific strategies.
Yeah. And I often I wean patients off of treatment in general, or I should say that I space out treatment. So I see them for maybe a longer period of time, but a lesser frequency.
Yep.
So while I see them initially maybe one time per week, I'll start to see them after maybe 3-ish, maybe 4 sessions. I'll see them once every 2 weeks. And then after another maybe 3 or 4 sessions, I'll drop down to once a month. And that way they're not as dependent on me. They're spending more time, out in their
the wild.
sport, in the wild. Yeah, they're able to go do their whatever they enjoy doing. But to bring it back to your initial question as to like when do I implement needling, during that initial evaluation, I'll ask them about their past experiences with healthcare. Most of the patients that come see me almost always have seen somebody else. And it has not given them the outcomes that they've expected. There's always some patients that have never, I'm the first person that they'll come see, especially if they're a direct referral from maybe a friend or a family member. But for those that have found me off Google, they typically have already seen other physical therapists, they've seen physicians, they've seen chiropractors, they've gotten massage therapy, they've done acupuncture. So when they come in to see me and I ask them about what they've tried in the past, well, if they've tried acupuncture, then they're usually a little bit more open to it. If they've tried dry needling, then they're typically more open to it. But I'll also ask them, when you got dry needling done, were the needles kept in, did they stay in you for 10 to 20 minutes? Are they left in situ for 10 to 20 minutes?
Did you let them cook?
Exactly, yeah. Did they let the needles cook for some time? Did they use electrical stimulation along with those needles? Because that will immediately tell me to an extent how the provider was trained. And if they don't leave the needles in situ, if they don't use any electrical stimulation, then they probably did pistoning. So I've had, I remember I had this one patient came in to see me for a hip issue. I met her during a workshop that I was doing on hip pain. Nice. And as she was talking to me about what she's dealt with in the past, she got emotional talking about how she has tried everything that she could think of, and she didn't want to get surgery on her hip. She was in her early 50s, and she got dry needling done. So I didn't bring it up to her afterward. I told her, just come in for treatment. Let me at least see what we can do. And if you don't have, if you don't feel the value in that initial evaluation, you don't pay.
Yep.
So she was open to try it out. So she came in for the initial evaluation. We definitely saw a heavy restriction in her hip mobility on her affected side. And we dabbled. We talked a little bit about dry needling on that day, but she didn't
Just
love
getting
needles.
her vibe.
Exactly.
Yeah,
she didn't love needles, and she had it done before unsuccessfully. Then I treated her that day. She had some pretty good results. She was already starting to see some pain relief. I saw her again. She got even more pain relief. And then closer to the end of that session, she said, I think I want to try dry needling next time I see you. So I built that trust with her first. I did other treatments to show her that I knew what I was talking about. And then I didn't even bring it up to her. She asked me if we could try dry needling the next session. So we did. So I needled her. We treated the hip capsule, but we also hit the glutes, the hip rotator, so like the piriformis, superior and inferior gemelli, the obturator internus, quadratus femoris. So when we targeted all these areas and the hip capsule itself, it was, in my opinion, looking back at it, probably a little bit too much dose for her.
Yeah, especially in one
first time.
Yeah.
And we can change the dose not just by how many needles we use, but how much we manipulate those needles, how long they're left in situ, how much intensity with the electrical stimulation.
Yep.
But when she got up, I could tell she was sore. So I don't have the patient leave the clinic immediately. We'll get them moving a little bit. We'll have a conversation. We'll go over their home exercise program, something, just so I don't make them leave when they're really sore. Typically after a few minutes, the soreness calms down.
Yeah.
At that time, I was subleasing from a gym. So the next day, she came into the gym to work out. And when I saw her car pull up, I got nervous.
Oh, we've all had those.
Yeah. And she walked in and she looks at me, blank face, and then she goes, I feel good. She smiled, and
it's always the outcome you're not expecting.
Yeah, man, I can tell you, I was incredibly happy that day because she had dry needling done in the past, unsuccessfully.
Similar, not similar techniques, but was it dry needling in the external rotators and the posterior side of the hip?
This is a little bit over a year ago, but from what I remember, I don't think they got as low as the rotators because you need to get, pretty low,
right in there.
Yeah, so it's in line with the sit bone, right? The quadratus femoris attaches onto the sit bone, onto the ischial tuberosity. So you gotta make sure they're comfortable enough to kind of have their waistband down well enough, and we drape them and everything, so we're respecting their modesty and all. But right. I don't remember her saying that they got that low, so I think they might have only targeted her glutes.
Gotcha.
But at that area where we're treating those hip rotators, we're not really treating the muscle anymore. We're treating the tendons of those muscles, which again, you can't treat tendons with they don't have trigger points, right? A tendon is non-contractile, so most of the time, if someone's only trained in trigger point dry needling, they don't know how to target a tendon. So for that reason, I don't think they did treat that low on this patient.
Yeah.
But thankfully, her hip pain is completely gone now.
Yeah. Well, it's all about, it all comes back to, these are all tools, but it comes down to the clinician when that tool is best fit. When usually it's like, I don't know if you've been guilty of this, but you take a seminar over the weekend that you geeked out about, and you're trying to fit everybody into that
into that category. Yeah, 100%.
Yeah.
And I warn that actually when I'm teaching dry needling, I'll let people know that, listen, don't forget about all the other tricks that you already know how to do. Dry needling can work well, especially when other techniques have not worked well on that patient.
Yeah.
If you've had a patient that's kind of plateaued, or maybe you're stuck and you don't know what to do, then dry needling might be a good option for them. But it definitely does not mean that you go into the clinic and start needling everybody that comes in. And people will ask me, do you needle every patient? And no, I don't. I will needle definitely a good amount of my patients. Obviously, I have a bias towards it. I read the research on it, I teach it, I do it a lot, I have good outcomes with it.
Yeah, and you have, exactly. You have your own personal experience with it.
Exactly. I responded well to dry needling. After my first experience with it where I got, my trap beat up and I didn't get any better, then I had another mentor who treated me for a headache, and my headaches got under control. And coincidentally, I had a headache yesterday, but I rarely get headaches nowadays. So he treated me for that. I've been treated for a lateral elbow problem with needles. I've had neck pain that I've had treated successfully with needles. So with that being said, I've had good outcomes personally, but I've also had good outcomes with my patients. But I don't needle every single patient that comes in. It's just, I do needle, I would say probably, it's more than 50% get needled at some point in their plan of care.
Yeah.
But there are plenty of patients that...
Which actually isn't that high for being... You're an instructor, right?
Yeah.
So,
it's more than half my patients.
Yeah. But as I remember going through, because I had the same questions going through my training, it's like, I would have thought that was easily 80%, right? But that's where it comes down to the skill. That's why I'm curious where if you always go maybe more instrument assisted or just other manual techniques, and then just through their kind of before and afters, like, hey, knowing when you need to maybe take it to that next level.
So it's a good question actually. So I do use some instrument assisted soft tissue mobilization, like the typical like the tools like Graston. I'd probably say I use that the least. I do cupping to some extent. I usually cup over maybe peripheral nerve entrapments. So if we find that like maybe over the common peroneal nerve over the head of the fibula. If it's overly sensitive in that area, if the fibula is not moving well, then maybe we can mobilize the head of the fibula, and then we can put a cup over the nerve, which has been shown to improve nerve conduction. But with that being said, my main focus is trying to get patients self-sufficient. So our first sessions are based off of giving them the tools so they can start to manage it on their own, especially being that I see patients at most one time per week.
Yeah.
So if I'm only
it's not the traditional physical therapy.
Exactly. Yeah. Where I used to be, it was 2 to 4 times.
See you in a couple days.
Yeah, exactly.
See you tomorrow.
2 to 3 times per week that we would see patients.
Right.
I had my old boss would tell me that based off of the research, they should be seen. I think it was like 2.3 times on average per week for the best outcomes. Which sure, they might get good outcomes if you're only spending 15 to 20 minutes with that patient. But if I spend a full hour with my patient, I mean, I'll tell you that I get way better results now than I ever have in the past.
Yep.
And a big reason for that is, when they're doing their exercises, I am there to cue them throughout their entire exercise.
Yes.
There's also good time under tension. We have tempos when we're doing our exercises. We can properly, progressively overload that patient. When we're doing our manual therapy, we have a little bit more time to do our manual therapy. Compared to in the past, it was, they're seeing a tech for their exercises. The tech is slammed with another 4 patients at the same time.
Yeah.
And then I might have 10, 15, 20, if I'm lucky, a half hour with that patient, but that usually isn't enough time to go over some lifestyle modifications, some of the irritating factors that they have throughout their day. A lot of my patients majority of my patients, it seems like, are desk workers, lawyers. I see a lot of lawyers. So I want to see what their setup looks like.
Not a bad patient base to have.
Yeah, actually, I very much enjoy training all my lawyers, but they
hopefully you never need them, right?
Well, my brother's in law school, so if I ever do, no, God forbid. But they are typically sitting in front of a desk a lot of the day. So I need to see their desk set up. I want to make sure that I know what they're doing for their activity outside of what we do.
Right.
If they are going to a specific gym, I mean, I've had patients take photos of the exercises, and then when they come in, I'm like, all right, let's see your exercises, and I'll make them do an exercise routine. I'm like, all right, well, your form on this is less than ideal. The nice way I can put this. I mean, I can't tell you how many people I have that are power lifters that can't deadlift. It's sad, honestly. Or people that are going to, if they're at a group fitness gym, there's one trainer with, let's say 8 people in that class.
Yeah.
They're not watching every single person's form. They don't have time for that. They're trying to move on to the next exercise. They have 8 people that they need to pay attention to, which is, you simply can't do that.
Yeah, I hate to say it, but those places are good for business.
They're great for business, right?
I've worked out in those group settings, and we're probably talking more of you probably got 10 to 20 people working on at the same time. It's just, you try to help everybody with their form, but yeah,
you can't.
sometimes
There's one gym that I belong to actually that I absolutely love because the owner there is the only trainer. Because he knows that if you want something done right, you essentially got to do it yourself.
Oh, yeah.
He also requires that everybody comes in for one-on-one sessions first. He makes sure that you have good form, and it's entirely kettlebell focused. Well, not entirely kettlebell focused, but a lot of kettlebells that he does at his gym.
which is all technique.
Exactly.
Yes.
So that's one reason why he uses it is because
If you could tame the bell, then you can do anything.
Exactly. It's a kettlebell is a great tool where you can't have bad form. If you do, you will get hurt. While with dumbbells and barbells, often people do get hurt, but you could also kind of, especially with machines, like you can kind of get away with crappy form.
You can compensate for a while.
Exactly. So this guy, I love his gym so much because he makes sure you have good form before he puts you in a group fitness class. But with all that being said, I will often have to go over people's form, and where I was in the past, when you're that busy, you just don't have the time to look over people's form. Also, most physical therapy clinics don't have barbells or kettlebells or dumbbells. They got mainly resistance bands,
Yes.
which can be good in a lot of scenarios.
Oh,
but
yeah.
I think chronically
One
we
tool.
underdose our patients in exercises.
Yeah. That's usually all they know is TheraBands at your big box places.
Exactly, and even so, they're very basic, like shoulder extension rotation type exercises. So even like bringing it back to needling, we can needle them, and then maybe we can use some of those lower level exercises just to prime the right muscles to activate. And from there, we can progress them past needles, and hopefully they don't even need the needling anymore, and we can just start loading them a bit more. And then if they have a flare up, then sure, maybe we can use needling again to calm it down.
Yes.
Especially if they've responded well to it in the past. But I don't want to be one of those clinicians who falls back to needles always.
Yeah, when in doubt, needle it out.
I've never heard that, but that's a great saying.
Yeah.
So I had a mentor of mine he doesn't really use needling too much, and I've learned a lot from this mentor. He's out in Massachusetts, and with his skills, he doesn't really need needling. He treats really well without it. But then after we talked a little bit more about needling, he saw that he was doing it in a less than ideal fashion. So we had a long conversation about when to use needling, different techniques with needling. But he says that he doesn't like needling because he finds that when people don't know what to do, they just put needles in it, which I absolutely hate, because then it starts to give needles essentially a bad name.
Yeah.
Maybe patients don't respond as well as you would want them to, because you're just guessing. So if you don't know what's going on with the patient, the needling, it might help, sure, but it also probably won't, because you don't know why you are needling what you're needling, or sometimes you just don't even know what to needle.
Yeah.
Kind of like those patients that, sometimes if you just put needles in it, it's going to get better. Just like those patients that are so sedentary that you bring them into a clinic, you get them moving in any way, and they get better.
A cat cow will change their life.
Exactly, just because they just need to get off the couch.
Right.
So same case with needling. You're like, sure, maybe you'll get somebody better doing it that way. But I can promise you, there are plenty of patients that maybe didn't need needling, or maybe they could have benefited from needling, but you did it in a less than ideal fashion. So that's why he hates needling. And since him and I have become closer and closer over the time that he has been a mentor of mine, I have kind of opened up his mind to it. And that's really how it should be, is like, I'm a mentor to others in relation to maybe manipulation and needling, and whatever I know, I love to pass that forward. But then I still have a mentor of my own, because there's a lot of other ways that I need to improve.
Absolutely.
As he is my mentor and I'm his mentee, I was able to teach him some techniques with needling. So in that sense, I became a mentor and he became a mentee, which is a great symbiotic relationship in order to, again, the goal is get patients the best possible outcomes.
Yes.
Regardless of the technique, regardless of the profession. There's a lot of hate within, I don't know how it is in chiropractic, but in physical therapy, there's a lot of disagreement. You go on social media long enough, you'll see physical therapists that hate on every single technique there is.
Oh, 100%.
And it comes to a point where I want to ask them, like, what do you do for patients? Because it seems like you just hate on every technique, where that could have been the technique that got somebody better. You cannot deny that these techniques have a place in rehab.
Yes.
If somebody speaks in absolutes, I immediately distrust them.
Oh my goodness. Yes. Yeah. If someone's, I have my bias, of course, but I'm not married to just one thing. If you're married to just one thing, I'm already like, ah. But my philosophy with it is, it's never the technique's fault, it's the clinician's fault, right? So if all these techniques exist, especially if they've been around for a long period of time, just like, say, like acupuncture, we know millennia at this point, where if it doesn't work for that patient, the assessment was probably wrong, and that's just not the type of treatment they need.
Yeah, maybe it's not the best treatment for that patient, which is why we need to have techniques in, I think, through different professions. You'll see if you pin the physical therapists versus the orthopedic surgeons versus the chiropractors versus the athletic trainers, the only person that loses is the patient.
Yeah.
And it is truly on us. Like, somebody's coming in, they're paying us money to help get them better, because it's just an exchange of trust, right? They're paying us money because they trust us to help them feel better.
Yep.
So that means it's on us. Like if I sent a family member to a provider and the provider couldn't figure it out, well, I would expect them to try to figure it out because obviously I don't know, or else I wouldn't have sent them the patient.
Oh, yeah.
So
Yeah.
if somebody comes in to see me, I recognize that I'm the provider that needs to help figure out what's going on with this patient. So maybe my assessment was off and I have to go back and reassess.
Oh, yeah.
Or maybe it just wasn't the right technique for that patient. I had this one mentor in physical therapy school. I love this saying. He would say, you only find what you look for, and you only look for what you know. So it means that you need to make sure you know what to look for in these patients. If you don't test it, how are you ever going to figure it out?
Yeah.
And then if you get an outcome that isn't what you were looking for, then you probably need to reassess that patient. I had a patient just a couple of weeks ago. She came in. It was for hip pain, and she presented entirely like a hip problem. So we treated her hip, and then I treated her. That was initial evaluation. We did a little bit of treatment. I saw her again. We treated her hip again, and I did needle her hip. Mm-hmm. And the next time I saw her, she said that she felt maybe 5% better. And I'm like, that means nothing. That means you got no better to me.
If I ask, like, hey, are you feeling better today? And if they hesitate for a second, I'm like, yeah, you're about to say.
No, yeah. And sometimes they want to be nice.
I was like, hey, you're here for you, not me. You know?
So they want to say something to make it feel like, because they don't want to offend you. But to me, like, she got no better. So I reassessed her. And the next time, when I assessed her, it presented way more like a lumbar spine problem. So it was just a lumbar radiculopathy. It just didn't present that way the first time because her body was hiding the problem really well.
Yes.
We started treating her back. I didn't needle her that day. I don't think I needled her even the following day. I did eventually needle her back, and her pain is like 75% gone now. Mm-hmm. All because and she had actually a recent flare because she just went camping, so she was like sleeping on the ground. But that being said, if I just was guessing and threw needles in it, and I kept throwing needles in it, it wouldn't have gotten better. I had to reassess that patient because she had the trust in me to exchange dollars. So that's just an exchange of trust, which means I have to make sure I do my due diligence to get her better. And needling in that scenario was not what she needed, especially because I treated the wrong body part.
Right.
Once I treated the right body part, her symptoms started to improve.
Well, and that's where it comes into, instead of just keep trying it over and over again, as a skilled clinician where 5% is not a lot. So I know that I'm probably looking in the wrong area. Mm-hmm. So it's like that humbling thing, like don't double down and be like, all right, now we're going to do 25 needles next session.
I recognize that I did not underdose her.
Yeah.
Like, sometimes you might have done too little, so maybe I needed to do more. But I recognize that I did not underdose her. She should have had more improvement. And because she did not, I knew that I missed something.
Yes. So then to crawl it backwards and be like, hey, this doesn't happen all the time. Your symptoms are presenting as hip, smells like hip, but I see like 5 hips a year that actually are referred, or the symptoms are coming from somewhere else. Just because I didn't see as much change as I wanted to, let me evaluate this other area, and then, by golly, it's a lumbar spine.
And they're open to it. I mean, patients recognize that we are human and that their body might not present the way that, like, it seems to always happen where a patient comes in like, hey, this hurts, and then they're like, of course it doesn't hurt when I'm coming in to see you. So they recognize that, we're not always going to catch everything in one day, which is the beauty of what we do as rehab professionals, is that we have time with our patients. They spend an hour with us, typically, at least in my setting, they spend an hour with me, and that's once a week at first. So like, I really start to get to know my patients, and sometimes it takes maybe 2 or 3 sessions to find out that they had one lifestyle factor that was keeping them in symptoms. Yeah. And unfortunately, based off of how insurance forces us to practice, physicians don't often get that opportunity because they usually get, if they're an insurance-based physician, they might get only 7 to 10 minutes on average based off of the research, 7 to 10 minutes on average with a patient, which is, shorter than I say good morning and it takes longer than 10 minutes with my patient.
Yeah, exactly.
So sometimes you have to dig in a little bit to their lives to figure out what their irritating factor is.
Yeah, if it was just muscle and joints, this would be very easy.
Yeah, the job would be so much easier.
Well, that's where one of my favorite sayings is, everybody and every body is different. So just knowing what different factors there are in their lives. Do they have teenage kids stressing them out, at work stressing them out? So there's always my patients probably heard me say this. There's always layers to the onion, but we're gonna find that low-hanging fruit and keep plucking it. A lot of times that solves their problem. If not, then we know, okay, we might need to start plucking somewhere else. Or I like to say you can have ticks and fleas at the same time. So you might have a musculoskeletal issue here, but you could have something more systemic based on dietary habits or poor sleep or looking at the more holistic view of the body. So yeah, it gets into the weeds, but that's where it's all about assessment. I'm sure you collect baselines like I do, movements or provocative things that they do, and then it's just before and after. Did that thing help? Did that treatment help? Did that exercise help? If not, then it's like, all right, maybe I'm looking in the wrong area. So it's just if you master that assessment, it's easy to marry dry needling to a patient, manipulation or adjusting to a patient. So it's all about the language of the assessment, I feel like.
I think a big part of it is also educating the patient in order for them to understand why they are doing the exercises. Way too often patients will stop doing exercises or they'll be very non-compliant, and it's really not the patient's fault. I would say it's more the provider's fault for for not showing the patient the importance of it. They should have some way of maybe feeling improved muscle activation, reduced symptoms, or just understanding that they have a movement fault that needs to be improved, and this is how we get there. This is the means to the end. And if we don't explain that to them, they're not gonna see with the exercise. They're gonna want you to they're gonna want to come in and have you do everything to them to make them feel better. When really we need to put things into their own hands.
Yes, which is a paradigm shift for me, because if someone's seen a chiropractor before, they think that I'm going to do all the heavy lifting, and I'm like, whoa, 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 whoa. Well, and that's where I tee it up, where it's like a traditional chiropractor, it's more manipulation. They might do some soft tissue, but not a ton of exercises. So it's like, hey, I'm going to tee you up for success. If I'm doing all the heavy lifting and I'm doing all the treatment, then yeah, I got to see you 2-3 times a week. But if we can offload some of that responsibility on you, not a ton, I just need you to do 5 minutes of movement a day. The more that you do, the less you have to see me, and the faster you're gonna recover. So just trying to like change it on there, and then every time you see me, you get more bang for your buck with the treatment because you're making that progress away. And it's a beautiful snowball effect into you getting better as soon as possible.
And I think the manual therapy is incredibly important, especially in the short term.
Yes.
Because when we get those short-term outcomes, that will allow us to get the long-term outcomes. I'm very much a manual therapy or a manual physical therapist.
I love treating, but just
they need to move at some point.
One piece in the puzzle.
Exactly.
Yep.
And a lot of it is us going over the exercises, and typically, I'll make sure they're doing it with proper form. If we're trying to load them up, sure, we'll do that all together. But if it's like a stretch, I don't know, if we're stretching out their psoas, like I'll show them how to do it. I'll make sure they can do it well, and then they're going to do that on their own before their workout. Because if they do it before the workout, they'll do it. If they save it till after the workout, they'll never do it.
Right.
And then when they come back in, we'll go over how to do it again, just to make sure that they are efficient, they're doing it well. But that is really how we got our outcomes. Now to bring it back to needling, because I had a sense we were going to digress heavily.
Yeah. We might just have to do like just a grand round, a 2-person grand round, and just see where it goes.
I wouldn't mind. So
yes. Hopefully, if you're a clinician, patients probably tuned out by now if they're watching.
Some patients are really into this stuff too. Actually, I've had patients that they're into like the Peter Attias, Andrew Huberman, and things like that.
Yeah. At least it's more mainstream now.
It is.
Yeah.
But because patients are now looking up dry needling, I think it's important for them to recognize, one, what the needling does, but also, what types of treatment with the needle you're looking for. Again, it's just the tool. So we can, like I was teasing to earlier, there's different ways that we can manipulate that needle, whether that is pistoning, which I never do, and then we can do coning or fanning, which is essentially, whether it's 2-dimensional or 3-dimensional, we're just kind of hitting that trigger point or the muscle in different areas. So we're not going back into the same area.
Right.
We're going in. We're changing the angle to target different areas. Because
Gotcha.
the error for finding a trigger point is 3.3 to 6.6 centimeters. The biggest needles I have, which I barely use, are 0.35 millimeters.
Yeah.
Most often I'm using 0.3 millimeter needles.
Right.
Again, the error is 3.3 to 6.6 centimeters. So we're not going to get it with one attempt at getting that trigger point.
Right.
So There's some ways that we can maybe have a little bit of a map. So sometimes we use some of the research based off of acupuncture, although again, I'm not treating based off of traditional Chinese medicine. There is between a 77 and 93% overlap between trigger points and acupoints, which is crazy.
Oh,
so
yeah.
it gives us a little bit of a map in order for us to know the common hot spots, but we still use our hands, so we still feel around and try to find those areas as well. But that being said, there's different ways of manipulating a needle, such as fanning or coning. There is winding, which we'll come back to in just a minute. There's tenting, which is essentially creating a little bit of a grasp with that needle. So we wind it until we're grabbing the tissue, and then we pull on it a little bit. For those of you that are watching the video, you put a needle in, you can wind, so you get a little bit more of an effect surrounding that that needle, and then you pull on it a little bit. So we're creating a lift.
Tugging it a little bit.
Exactly. We can also do periosteal pecking, which is getting down onto the bone and then tapping on the bone, which works incredibly well for osteoarthritis, which patients always feel like, they're bone on bone, so there's no solution. They need a joint replacement, which sure, joint replacements have their place. Don't get me wrong.
Yes, but that doesn't happen overnight.
Exactly, and then ideally, we can maybe get them to delay that joint replacement or avoid it altogether.
Yep.
And also, I guarantee you look at your other knee, it's also bone on bone, but there's only one knee that hurts. So the bone on bone can't be the reason that you're in symptoms. So that being said, we can treat their osteoarthritis by doing some periosteal stimulation. We also, there's a really cool study, one of my favorite studies I've ever seen.
Okay, upper echelon.
I haven't been saying references, but I guess I will. So this is Mayoral 2013 is the author in the year. This is a study that was done in knee replacement patients. And this is prior to their knee replacement. They had somebody come in and palpate for trigger points in their quads. And then they all went under anesthesia. They're all about to get a knee replacement. They needled half and didn't needle the other half. And then they followed them for, I believe it was 6 months. After the surgery and after up to 1 month following the surgery, they had significantly less pain in the group that had dry needling done compared to the group that did not have dry needling done.
That's one session when they're under?
One session, while they're under, just before the knee replacement. And it was well blinded.
They didn't even know it was happening, right?
The patient didn't know who was getting needled. The surgeon didn't know who was getting needled. And the therapist who did their assessment after, they did their rehab after treatment, or after their knee replacement, the therapist didn't know who got needled. So it was really well blinded.
What a top tier study.
And they also followed it based off of the natural history. So the group that didn't get needled followed the same trajectory as natural history, the way that they have been improving over the natural history of knee replacements.
Right.
The group that got needling done had significantly better results up to 1 month later. And then at 3 months and 6 months, it normalized. So it was about the same afterward. But that first month is crucial for range of motion.
Yeah,
right?
absolutely.
And also, who doesn't want to be in less pain after a knee replacement?
You'll take anything you can get.
Exactly.
Even if it's 5%. People still pop a lead for 5%.
Exactly.
You know what I'm saying?
So those are the ways that we can manipulate a needle. So again, that was coning or fanning. There is winding, tenting, and then periosteal pecking or stimulating the bone. We also will leave needles in situ for typically 10 to 30 minutes. That's for the best outcomes. Less than 10 minutes, not the best outcomes. And then more than 30, there's no superior outcomes. So we keep it within that range. Typically, I'll keep them in for between 15 and 20 minutes.
Yeah.
And then we will also come back and wind the needles again. So we spin the needle. And part of doing that is we wind up collagen fibers and connective tissue around the needle, just like you wind spaghetti around a fork. We're also able to affect the tissue a little bit of a distant area from the needle itself. Again, if I put a needle in one spot, I can only affect that one spot. But if I wind the tissue around that needle, I can affect an area, the study shows, centimeters away. It didn't say how many centimeters, but it used the word centimeters in that study.
Yeah, so we know we're at the micro level. I mean, the tool is
tiny.
Yes.
So we're able to at least affect it at an area away from just where that tool specifically is. And then another reason we wind the needle is we promote a chemical called adenosine. Adenosine is a potent vasodilator. It will help with pain, and then it downregulates an area in the brain that is associated with the emotional response to pain. So that area is called the anterior cingulate cortex. It's just this area in the brain that lights up when there's an emotional response. So that could be for people that maybe feel like they have lost their purpose, or they're a burden on their family. Maybe they can't work anymore.
Yeah.
With any of these patients, we can start to reverse that effect just from winding the needle. Now, I'm not a mental health provider, so I refer appropriately for those that have mental health Maybe they have a trauma from their physical trauma, they have an emotional trauma.
Of course.
So we refer appropriately. But it's not uncommon for patients to just talk to us about their life when they spend so long with us that they just feel comfortable with us.
Well, and once you do that, you can start to get them to realize what's going on in their everyday, such as like, hey, you mentioned this thing's been stressing you out. You've also had more symptoms since that event. Like getting them to connect the dots that their everyday could be leading to their symptoms that they're feeling too.
100%. And vice versa, their symptoms can be leading to their everyday, right? Because if they have, maybe like a knee issue and they can't even go up and down stairs without pain, they almost feel nervous to go down a set of stairs. I mean, I had a problem with my left knee where when my son was first born, I couldn't go down the stairs without a feeling of my leg giving out on me because of the sharp pain. So I couldn't carry my son, my newborn baby, down the stairs, which as a father was a little bit, it was a little bit emotional, right? Like I'm supposed to protect and provide, and I couldn't even do that for my own family because God forbid there's a fire or something, and I'm sure, maybe an adrenaline rush would get us out of the house.
Yes.
But just knowing that I have an issue going down the stairs, that I had to have my postpartum wife take my son down the stairs because I was in too much pain to walk down the stairs myself holding my baby, was a bit emotionally taxing. So again,
100%.
just by promoting that adenosine, by winding the needle, we can help downregulate this area and maybe get a little bit of an emotional release. But again, we're referring appropriately.
Yeah, that's more of a secondary effect that could happen.
Like
you're not going to say no to it.
Yeah, I'm not going to say no. Exactly. So I'm treating their pain, but like if I can affect their emotional life, like sure, why not?
Yes.
The other really cool thing about adenosine is what helps you go to sleep at night. So adenosine is just built up over about a 16-hour period, and it helps you with the timing of sleep. So like that feeling of like it's time for me to go to bed, but also helps you actually fall asleep. So the generation of sleep, compared to melatonin, which only helps with the timing of sleep. So if you've ever taken melatonin, you might feel like you're lying in bed and you're miserable because you want to go to sleep, but you can't fall asleep.
Yeah, I don't mess with it.
I don't blame you. So adenosine has like that effect of melatonin where it helps you know what time to go to sleep, but also will help you actually fall asleep.
Nice.
For those of you that are interested in sleep, I would highly recommend listening to Matthew Walker. He has a good book called Why We Sleep, and it dives way deeper into this. But I'm a little bit of a sleep aficionado. I love sleep. But it's really cool that when we needle and we wind that needle, we can promote adenosine, which might also help them with sleep. There are some studies, these are acupuncture studies, where they've needled for this is in a military population. This is two different studies. One of them, I believe, was on anxiety and depression, and the other one was PTSD and insomnia. But all four of those improved from needling these patients, from doing acupuncture, traditional Chinese medicine, I believe, in those studies.
It's a powerful tool.
But it's really cool that we've seen in dry needling studies that we can reduce pain and improve that adenosine release, which again, we know that adenosine will help with sleep. And I mean, I needled you earlier. How did you feel after we put needles in your head?
Oh, I can nap right now.
Yeah.
I'm awake, but you dim the lights a little bit in here.
So I typically tell patients that you'll probably sleep really well tonight. We're kind of expecting that. So make sure you use that to your advantage. Once you start to feel a little bit sleepy, like go to bed. Because if somebody can't sleep, they can't heal. So we know that we can get that, at least partly get some of that effect from needling. So again, that's from winding the needle that we promote adenosine. We're again winding up collagen fibers. There's studies that show that we can promote stem cells in the body from needling. We are inducing an endogenous opioid response. So the body will make its own painkillers and send them over to that area just from the needles. We also promote cortisol, which sounds like it's a bad thing, but cortisol is just a normal, it's normal for human function. We have a huge cortisol release first thing in the morning, but we promote cortisol, which can inhibit COX-2. COX-2 is also what ibuprofen is trying to inhibit. Although ibuprofen also inhibits COX-1, which is why there's gut irritation from it.
Right.
That COX-2 inhibition can get us some more pain relief. Like we talked about earlier, we are inducing a small inflammation. So that inflammatory response is the first phase of healing, but there's also anti-inflammatory effects. So we can both be anti-inflammatory for chronic inflammation, but then we are promoting an acute inflammation for the body to heal itself. And then we still get into trigger points. So trigger point dry needling, it's still something that we do.
Yeah.
We're getting into these trigger points. We are using up the remaining acetylcholine, which is the neurotransmitter at that junction where the nerve meets the muscle. So if we can use up that acetylcholine, we might get a twitch response. But we're essentially going to get that neuromuscular junction to finally reset. And again, when we get all of these effects in our patient, we have less pain, improved muscle activation, and that way, when we do our stretch or our strengthening, whatever it may be afterward, we typically have a lot more bang for our buck, and that is why we can get some of the best results for our patients if we include dry needling. Again, it is not everything, and if you were needling everybody that walks in the door, you're probably missing. You're probably just guessing. You're just putting pins in a pin cushion at that point.
Literally throwing blind darts.
Exactly. But if you can use that modality effectively and when it is best used for that patient, you will have, like I said, I get better outcomes than I ever have in the past. And there's always ways to improve, which is why I still have mentors of my own.
Oh, yeah.
But dry needling itself can be an incredibly effective tool for getting patients out of symptoms. And if you treat TMJ dysfunction specifically and you do not use needles, then you are leaving results on the table.
You're missing the boat.
Yeah, you can send them to, obviously most people that have TMJ dysfunction, they've already gone to their dentist. They've already had a night splint. But there's even a study that
use this mouth guard overnight.
Exactly, and it can work.
Yeah.
But for those that
it doesn't,
for those that it doesn't work for, what do you do? So there's this is a study that just came out. I believe it was in 2021, maybe 22, where they compared joint mobilization. So physical therapy, they got joint mobilizations done, and then they also had a night splint. And they were able to take diclofenac, which is an NSAID, so a non-steroidal anti-inflammatory drug. So all three of those compared to just cracking the neck and putting needles in the jaw. And that had better results than the night splint, traditional physical therapy, and medication. So that being said, for TMJ dysfunction specifically, it is something that's probably the one thing where I don't think I can treat it without needles.
Okay.
Everything else in the body, I can treat without needles, although I think I'll get a better outcome if I can use my needles.
Yep.
But TMJ dysfunction specifically, I need needles to be able to treat that properly. So, it's nice to know how to use that tool, to use it well. It doesn't mean it's for everybody.
Right.
But that means that when it is appropriate, then I use it. Same thing with spinal manipulation. I don't manipulate everybody that comes in the door. But, when it is appropriate and I can utilize that, it's pretty cool that I know how to use that tool.
Absolutely. Yeah, you want as many tools in the tool belt as possible.
100%.
Right? All right, well, let's wrap this in a bow. I think this is only going to be part one. Obviously, we just met last week. We liked each other enough to meet back-to-back weeks. They're in a busy professional schedule.
I'm hoping that we can even have maybe a video episode where we just practice our maybe teach skills to each other.
Yeah, if you want to see how a chiropractor treats a physical therapist, and how a physical therapist treats a chiropractor, especially with manipulation or adjustments, I think that would be cool.
I would absolutely love that.
Yeah, maybe we'll work that. Actually, we're for sure going to do that. But if you're interested, leave us a like, comment, and all that jazz. But I think we got a good overview of dry needling. If anything, we might go into other aspects, whether clinicians are listening when it comes to your self-pay practice proponent. So I think that's cool if clinicians can hear that, especially from the physical therapy side. Super common or more common, I should say, for chiropractic, but I'd be interested to hear more about that. And this man is a wealth of knowledge, so if you want to hear us riff about anything, let us know and we'll make another episode for you. But let's plug one last time. Who you are, where you're located, your practice, everything.
So again, my name is Osama Imam. I'm a physical therapist based out of Bloomfield Hills, Michigan. My practice name is Dynamic Physio. Feel free to follow me on Instagram. My Instagram handle is @thedynamicphysio. My website is dynamicdpt.com. And then, you can follow me on LinkedIn and Facebook, but I am absolutely horrible at social media.
What if they're interested in dry needling? Where can they just reach out to you?
Yeah, so if you guys are interested in dry needling, I would highly recommend you check out spinalmanipulation.org. Again, that is the organization that I teach through, so that's the American Academy of Manipulative Therapy. We have a lot of classes that we offer. My specialty is dry needling, of course, but we do have classes in things like blood flow restriction, obviously spinal manipulation, vestibular and concussion specializations, ultrasonography, which we do ultrasound guided dry needling, which is a whole other topic. Both all that being said, if you guys are interested in dry needling, I would highly recommend the American Academy of Manipulative Therapy and Dry Needling Institute.
And if you're a clinician, I'll link your school page.
Please do, yeah. So I have a online community that is designed for manual health professionals. So that's really physical therapists, chiropractors, a couple massage therapists are in there. But we talk about any and all things that are clinic based. So whether that is manual treatments, we do have some exercise things that we put in there as well. But especially with the graduating class of both chiropractors and physical therapists that went to school during COVID. I mean, they basically went to school online. So they missed out on a lot of the manual health or manual treatments. And that's part of the reason why we have the school community. So this community is based off of us being able to really learn from each other and teach each other because, there's only so much that I can do one-on-one with a patient. But if I'm able to maybe pass some of that knowledge forward and someone else can use that to benefit their patient, or vice versa, if I'm struggling with the patient and I can learn something from that community, then we're just able to really help improve healthcare as a whole and help make this world a little bit of a better place.
Heck yeah, a rising tide lifts all boats, right?
That's the plan.
All right,
I appreciate you
man.
having me, Mitch. Thank you so much.
You'll be back on.
I'm looking forward to it.